very warm good evening to all of you. So we are changing a flavor a bit. A lot of heavy stuff has been given to us, and with after Dr. Mehta's and Dr. Amit's lecture, thoda sa we'll make the environment a little lighter. So Dr. Nitesh and Jatin are here, and so this is like the format is like a talk show. It's not a moderation or a lecture, and so it's a breast cancer talk show we are having now. So it's a new format. So breast cancer is, of course, we know it's a very important disease, and day in day out we are saying, that's one of the most important part of our day-to-day practice. And so we have early breast cancer, we have metastatic breast cancer, and although we think we know a lot about this disease, but there is so much to discover and so much to still do, and so many areas which are still unmet. We require more. So we are focusing here mainly on HR positive and HER2 negative, node positive early breast cancer, as well as the metastatic hormone receptor positive breast cancer. So these are the patients who are at higher risk, being node positive. So we are discussing this in form of 3 sections. So in first we are will be taking up the unmet needs in hormone receptor positive, HER2 negative, high risk early breast cancer. And so, Dr. Nitesh, in your clinical practice, what characteristics render EBC patients at high risk of recurrence in their treatment journey? So we know we take it to be a generally good prognosis, but still there are high risk patients, and a lot of these patients still, they recur. They are not doing that well. So what is happening? What are the features where you are thinking like that?
I think before we start talking about risk and early breast cancer, we have to understand that all of this is based on very strong data-centric modeling, right? So the entire inclusion criteria, whether we take monarchy or whether we take ribociclib or even metastatic disease, right, is really based on first teeing out a long epidemiological data set, and then from that you picked up the risk of recurrences, and then you said patients who were actually having more early recurrences rather than late recurrences, which was that group. And of course the logical conclusion will be high lymph node positive, so more than 10 lymph node will always be worse than more than 1 lymph node, high grade tumors, big T size, and then came in those smaller factors, moderate and no PR, came in lymphovascular invasion, will come in your high Ki-67, and so on and on, and maybe now even oncotype DX high risk scores. So what I'm saying is all of that is first based on data centricity. And it's a question worth asking, do we have that level of data to know what are our high risk patients? Of course, 10 node positive will be high risk whether they're sitting in UK, US or Singapore or India. But really is a moderate PR in a 45-year-old high risk in an Indian context versus an American context? I think these things we really need to understand before we say what high risk. I think I've partly answered the question to my mind.
Dr. Jatin, would you like to add some more features here?
Yeah, first of all, thank you for inviting me. And I totally agree with him that it was through the data we came to know, yes, there are certain subsets who progress early, may have some primary hormone resistance also, and usually we have seen that they relapse, but the relapse in ERBR positive is usually late. But it's a bad relapse most of the times. And yes, there was an unmet need for a certain subset of patient. These data are all based in US and all, where you tend to have a screened patient most of the time and you don't get such advanced cases. It's a different story altogether.
The patients are definitely
our
more,
patients, the chunk of our patient who might be higher risk, and the node positivity is the most important factor among them. So we routinely see more than 4 positive nodes. So Yeah, there are high risk patients.
For,
Yeah.
for example, I still don't know the answer to this. Maybe you or somebody can answer this. So, you find a heavy node positive neoadjuvant patient, a ERPR positive, HER2 negative, and the response after treatment is still a significant residual disease, right?
Yes,
And
that's the
it's a
user
high
story.
risk. But actually, if it goes into pathological complete response, I'm very worried
You'll
about
be
this patient.
surprised.
I would not surprised. I would be worried because
Yes.
this is actually behaving like a luminal beat.
Yeah.
So I don't know how to define that risk categorization in my practice other than some very obvious ones.
Yeah. So PR being negative is another, area where you don't know how much hormone sensitive this tumor is going to be. Yeah. So we'll be looking at some more subset of these patients. So now based on this high risk EBC criteria, so how do your treatment outcomes would differ in terms of let's say risk of recurrence or risk of modality? What extra would you do for these patients?
Well, definitely. I mean, when we thrash out the high risk subset, they obviously high nodal subset or PR negative subset. Well, ER positive, PR negative, as such, 30% of them are relapsing early. They are not sensitive to hormone. So the risk of recurrence is certainly high. And in this high risk subset, and suppose they relapse early, say within 3 years or just more than 3 years also, they tend to behave really bad. They tend to behave as bad as a triple negative breast cancer, and this might I mean most of the people have experienced that. They are very resistant cases, and they have all kinds of metastases, liver mets, brain mets to that extent, and they don't respond to treatment really well. We have some personal experience of really bad patients of ERPR positive who are hormone resistant, a very bad subset of patients, and there have been some data also regarding that.
So most of us have encountered such patients where we initially thought these patients are going to do well, they are ERPR positive, but eventually they did not. And the risk of recurrence is, recurrences within 2 years, within 3 years were really high in such patients. And
But going back to that previous point, uh, end of the day, this is breast cancer, this is early breast cancer. I would always put mortality data first. And I know every patient when asked would say actually recurrences is as important, but I would still put mortality data and overall survival a very important criteria because you don't want to be doing some catch-up therapy and then say, you know what, it was equally good. Why expose everybody to
yeah,
X
so
amount of
as Dr.
treatment?
Jatin pointed out, so the patients who are recurring, who have primary this endocrine resistance and they are not benefiting from the initial treatment, they are actually doing as bad as some
Yeah,
of the
yeah.
triple
Yeah,
negative
yeah,
patients.
yeah.
So that data again, we have some of that information available with us. So now coming to, so what are the some of these less favorable prognostic factors? So which you would consider when you have such a patient who is ER positive and HER negative in metastatic setting?
Well, metastatic, the you want to put?
Yeah, okay, sure. So I always look at volume of disease first for in my mind. So anybody with large volume metastatic disease, especially visceral organ, brain being the worst, lung, liver being second, and then comes in lung and everything else is always a big concern. As much as bone is considered good, actually large volume bone is in fact bone marrow also, and that troubles me. So volume of disease. At metastatic site, a loss of PR in my observation is a very bad marker. Somebody was ER8, PR7, and at recurrence has come with a PR0 is very bad. And same with the change of grade. We are now doing KI67 routinely for whatever it's worth. A patient who had a KI which was sitting in 15, 20, we've suddenly seen it jump to 45, or the grade 2 tumor, grade 3 with a high KI, low PR. These are bad factors. So visceral met, large volume disease, obviously severely clinical symptomatic, and a drop in PR is very, of course, a drop in ER or a change in biology even worse, but drop in PR.
And some of the
Just
other
want to
point,
add
like
one or
from
two.
the time from, you know, the adjuvant
So
treatment,
primary
those factors would
hormone
also be
resistance, yes, the hormone resistance, primary hormone resistance is a very, very important point. And the second, I would say, among the visceral also, the liver metastasis, they behave really bad. They behave very bad. And many a times, it's a terminal event sometimes when we treat metastatic breast cancer, and we really need to rush to make a decision what kind of therapy we have to employ. So these are just two additional points.
Yeah. So very rightly said. So we'll just summarize this section here. And so these are, so approximately, 1/3 of these patients would experience relapse. And the factors could be young age, tumor morphology, high volume disease, larger tumor size, grade, and if patient is more symptomatic, LVI, high nodal involvement, and negative ER or overexpressed tumor HER2 status, positive margins, PR negativity, high KI, and metaplastic carcinoma. And if we see the real world evidence, so the risk of recurrence in, so let's see the Monarch E data. So here the patients who were taken in Monarch E, so these were the high risk patients, and it is seen that the 5-year risk of recurrence is nearly 3 times in these patients, in this subset of patients. And the prevalence of these patients is more than 1/10. So let's say about 14-15% of this population is actually at high risk, which requires, some more intervention than what we are doing. So what is this population? More than 4 nodes or 1 to 3 nodes with either grade 3 or a bigger tumor size of more than 5.
I mark that again. This is US flat iron data.
Yeah.
Yeah. So by just simple guess and observation, ours is likely to be more than
It's
14-15%.
likely to be more, exactly.
We'll be having a 25-30%.
Because our patients' nodal this
is likely to
positivity
be
would
higher.
be
Younger age group is
absolutely
more
high.
common.
Yeah.
So yes.
And if we see, so this is again a very important slide. So let's assess the mortality risk by intrinsic subtypes. So the graph on the left hand side, so the ER positives, they are going to do better here as compared to the TNBC. So this we all know. But look on the right side. So the increased risk of mortality was observed in HR positive HER2 negative subtypes with high risk characteristics. And if we see the curves, the two curves on the lower half, so they are almost merging. So this subset of patient is behaving badly and the prognosis is poor. So this is what we need to impress, that the high risk category, we need to be alerted and we need to do something better than what we are already doing. And so the prognostic factors as we discussed, so the ER/PR positive patients, so they could be highly sensitive depending upon whether it's a de novo metastatic with a low volume disease, asymptomatic, bone only, to some kind of sensitive profile with some maybe soft tissue mets with the endocrine. So there is gap of nearly more than 12 months after stoppage of the endocrine therapy, the adjuvant therapy, moderately sensitive where there is short DFI post adjuvant endocrine therapy, versus, so we have, the more symptomatic, more volume and primary resistant patients where the expected benefit of further interventions could be less. Yeah. So the more the time gap from adjuvant endocrine treatment, the better the patient may benefit from further interventions. So I think anything more you would like to add here?
I mean, this covers most of it, but clearly some symptoms and clinical manifestation will also
matter. Yeah. So we have more symptomatic and more visceral disease patients.
More volume.
Yes, more volume disease. So coming to the second section, so when we are discussing the ER positive patients, now we have Monarch E data here recently. Now we know the entry criteria here. So we will discuss focusing on cohort 1 basically. Most of the patients were in this cohort, more than 4 positive nodes with or 1 to 3 nodes with grade 3 or with tumor size more than 5 centimeter. So they were randomized with the abemaciclib plus ET versus only endocrine therapy. And so we are looking at IDFC. So IDFC is the latest criteria which is being followed to assess the prognosis and the benefit here. And if we look at the 4-year follow-up, and we can clearly see there is 6.9% difference here in the IDFC. So invasive disease-free survival. So IDFC we know is a very comprehensive marker here. So where we assess all the kind of recurrences, whether it is ipsilateral, contralateral,